Hello. Let's talk about Klinefelter syndrome and Turner syndrome. Let's start with Klinefelter syndrome. I want to go straight to the pathogenesis to explain to you why one sees the clinical picture of hypogonadism as they do in Klinefelter syndrome. So if you have an XXY karyotype, got two copies of the X chromosome, and due to X inactivation, one of these two X chromosomes at random within any given cell is going to become a bar body, and that means it's just going to coil up and repress its genes. However, in Klinefelter syndrome, we observe something called non-random X inactivation. And this is kind of a frontier of science. You might even call it some wizardry going on. We don't exactly know why things are going on as they are in Klinefelters, but what we do know is that in contrast to what normally happens in all females or any cell in the body that has more than one X chromosome, normally it's totally random which X becomes the bar body and which X is allowed to stay active. But in Klinefelters, the X that gets inactivated is always the X chromosome with the androgen receptor with a short amount of CAG repeats. So that's like, what is that sentence telling me? You know, it's like, okay, let's read this whole paragraph and break it down. As in the case with normal females, all but one X undergoes inactivation in the cells of patients with Klinefelter syndrome. So then why do the patients with this disorder have hypogonadism and associated features? The explanation of this lies in the pattern of X inactivation. The gene encoding the androgen receptor, so the testosterone receptor essentially, maps on the X chromosome. The androgen receptor gene contains highly polymorphic CAG trinucleotide repeats, just like Huntington's. The functional response to androgens is dictated by the number of CAG repeats in this polymorphic sequence of the androgen receptor genes. We have learned through observation that shorter or a lesser amount of trinucleotide repeats correlates to a greater androgenic effect whenever testosterone or dihydrotestosterone binds to the receptor. And then that would mean that the inverse is true. If you've got more CAG repeats in the polymorphic section of this androgen receptor gene, then androgens will mediate less of an effect when they bind. And so you would have, quote unquote, an androgen insensitivity if you were to have a lot of CAG repeats in that transcript of your androgen receptor. So what ties this all together is understanding that in people with Klinefelter syndrome, the X chromosome with the androgen receptor with the shortest CAG repeat is inactivated. Every time. It's not random. That's what mediates X inactivation in Klinefelter syndrome. Now, I don't know why. I got no clue why. You don't know why. Nobody knows why. But it's just something that we have observed and we've seen it to be true. And so you and I, the students, we just got to deal with it and understand it and remember it. So that's the pathology underlying Klinefelter. Now we can start to build up our body of knowledge about what this syndrome is based off of pathogenesis. So boys get Klinefelter. Why? Well, because there's a Y chromosome right there. So anyone with Klinefelter is a guy, not a girl. Up until puberty, you can't tell the difference between a patient with Klinefelter and any other boy in the world. They are indistinguishable from other boys with normal karyotypes. Now, when you hit puberty, because of this androgen insensitivity, you've got a hypogonadism. And it's so severe that even the cells of the seminiferous tubules fail to develop properly. And so you get hyalinization of the seminiferous tubules. there are just no sperm in them. There's a very low germ cell concentration once you hit puberty. And then you also see this Leydig cell hyperplasia. So there's a characteristic histology to go with the characteristic body habitus of patients with Klinefelters. So that body habitus, we're looking at it right here. A slight degree of gynecomastia in post-pubertal men, and also a hypogonadism. So that means that there's diminished functionality of the gonads, not the size. When we say hypogonadism, we don't mean small gonads. If that were the case, there would be a lot more cases of hypogonadism out there. But when we say hypogonadism, we mean that they're not functioning properly. So you have that, and then you also have some fairly feminine hips on men with Klinefelter syndrome. And they're going to be taller than average. They have a characteristic habitus that is not going to be very difficult for you to remember. Now, some patients can be mosaic, meaning some of their cells are 47XXY and other cells in their body have a normal karyotype. That's a minority, and these patients have a more mild clinical picture. Also of note, there are some variants with more than 2 X chromosomes, which are going to be more severe in their clinical phenotype than a 47XXY Klinefelter. So that's what they look like. That's the characteristic presentation you'll see around puberty. This characteristic habitus starts to develop. So taking it from the top of this section, it's the most common disorder of sex chromosomes in humans. And it's due to nondisjunction, and I've linked a video below in the comments to a visual representation of nondisjunction if you still haven't nailed this concept down in your mind. Now, maternal age, and I suppose paternal age too, but really maternal age, because you don't make new eggs throughout life like men do. Men just make new sperm every other day practically, but women make a certain amount of eggs and then they're there and they're safeguarding them for a very long time. And so those eggs are susceptible to damage. And so that's why the likelihood of any non-disjunction, not just for the X chromosome, increases with age. And that's the same mechanism for why Down syndrome is more common amongst older mothers, because that's also an episode of non-disjunction. 95% of cases of Down syndrome are due to non-disjunction of the 21st chromosome. Now, key to understanding Klinefelters is that these patients, again, are totally normal until they hit puberty. And that means that their blood panels are normal too, and their hormones as well. They're going to have normal blood LH, FSH, testosterone, anti-Müllerian hormone. You really can't tell that nothing's wrong with these guys. But then during puberty, due to this androgen insensitivity caused by the non-random X inactivation, gonads fail to differentiate into adult testes. And the key hallmark is a loss of functionality of Leydig cells. They don't go away like microscopically. You can still obviously see a large degree of Leydig cell hyperplasia right here that I've circled in green in this lower left photo. So the Leydig cells are there, but they're just not functioning correctly because of the androgen insensitivity. So if these Leydig cells aren't functioning, they're not making as much testosterone, because these are the cells in men that produce testosterone. So if you're not making testosterone, you're not making a lot of sperm, hence the infertility in most Klinefelter patients. And if you're not making sperm, you're not making a lot of this substance inhibin. I think it's inhibin B. And so if you're not making inhibin, then your anterior pituitary has no reason to stop making follicle stimulating hormone. And likewise, in the vein of negative feedback, if you are not making a lot of testosterone, well, testosterone feedback inhibits the pituitary to stop the release of FSH and LH. So if you are not making a lot of testosterone, you have no reason whatsoever to slow down LH production. On the other hand, it's going to be increased because you're going to realize that you need more testosterone because you won't see it in the bloodstream. Your pituitary won't perceive it. So you'll crank out the GnRH and you'll crank out the LH and the FSH, and that's the characteristic lab finding of Klinefelter syndrome. It's called hypergonadotropic hypogonadism. So hypogonadism, what's that mean? That means that the genitals aren't functioning. They're not making testosterone. They're not making sex cells, germ cells. They're not producing them like they ought to be. But then the hypergonadotropic part, what does that mean? Well, gonadotropic, tropic means growth. And so GnRH, that's what gets the growth hormones made in our pituitary going to the gonads, the ones that they'll respond to, LH and FSH. So that's our gonadotropic hormone, you know. So if you have a high level of GnRH in the blood, we would call that hypergonadotropic. And so there's a little differential tree there. There are a few causes of hypogonadotropic hypogonadism. But the high level of GnRH and thus FSH and LH is what keys you in, clues you in without having to do a karyotype. This patient probably has Klinefelter. So why is testosterone low? Well, first of all, Leydig cells aren't working as they should be because of that decreased androgen sensitivity. But also, in a patient with the 47XXY karyotype, aromatase, this enzyme's expression is increased about 4 times compared to normal. So what does aromatase do? Well, it takes testosterone and it makes estrogen out of it. So that takes an already low pool of testosterone and just pulls from it even more and depletes it even further. So that low testosterone, that finding, it should make sense to you then why LH is going to be up in these patients and FSH is going to be up in these patients. Finally, associated abnormalities, important section for test questions. Breast cancer and germ cell cancers too, actually, testicular germ cell cancers are, if you have Klinefelter syndrome, you are more likely to get a breast cancer or a germ cell cancer. Some autoimmune diseases are more common in Klinefelter syndrome. And then intellectual development is a really broad finding that it's hard to ask a test question about, but something that's really easy to just put into a multiple choice format would be osteoporosis, increased risk of fractures. And this is because testosterone exerts a very similar effect on bones to estrogens. So estrogens are very protective to bones. We know that they activate osteoblasts and they tell osteoclasts to kind of cool it a little bit. So androgens do something very, very similar. Androgens and estrogens are very similarly shaped. And so if you have low testosterone levels, especially during puberty, when your growth velocity is peaking, then you're not going to reach a normal peak bone mass. You'll have a little bit of a depleted bone mass in comparison to your peers. And so by the time you hit your mid-30s, your 40s, when your bone is just degrading, eroding naturally, well, then you're really at a greater risk for osteoporosis, bone loss, and fractures. So that's Klinefelter's, kind of a wonky disease, kind of complicated, but easy to recognize, fortunately. Turner syndrome, the 45 single X karyotype. Whereas Klinefelter's is always due to some chromosomal non-disjunction. I won't say always, but usually. Turner syndrome is tougher to pin down. There are many different ways that you can acquire Turner syndrome. So non-disjunction is the classic form of the disorder in which whenever a cell divides, it makes two daughter cells. And so in non-disjunction, one daughter cell is going to have both of a given chromosome, in this case, the X chromosome. And then the other daughter cell is going to have no X chromosome at all. And so if this empty cell gets paired with a sperm carrying an X chromosome, let's say, well, then the result after fertilization is going to be an egg or a newborn with that XO karyotype, genotype, because of the empty egg that resulted from non-disjunction. So that's about half of Turner syndrome cases. You see some mosaics pretty commonly, and so that would be what we would call a somatic non-disjunction, not a germline non-disjunction, but a non-disjunction that maybe happened in the 8-cell or the 16 or 32 cell stage. And that accounts for roughly a quarter of Turner patients. You might see the isochromosome XQ. You might see total deletion of the P arm of X. And so what's the difference between an isochromosome XQ or an XP deletion? Well, with isochromosome XQ, you've got extra copies of the Q arm, versus with the XP deletion, you've just got one Q arm and no P arm. And then finally, you can see a ring X chromosome. And I bring up all this stuff to remind you about the fluorescent in situ hybridization that we took a look at up on page 2. Unlikely you get asked about that in this method, but possible. So just be on your tiptoes. So two things happen in Turner syndrome, very characteristic. Number one, these patients are short. And then number two, these patients have lymphedema. And there are a lot of somatic qualities downstream from the lymphedema, including web neck, lymphodematous hands and feet. They'll be puffy, but it won't be pitting edema. Low hairline, broad chest. So that's the two big things you want to know about Turner syndrome for this SDL, because whenever we walk through the pathogenesis, we're really looking at the short stature. And then I said lymphedema, but thinking about pathogenesis, starts talking about premature ovarian failure, which is another not externally noticeable finding in Turner syndrome. You see what's called these streak ovaries. And the streak ovary is named because, well, it's a streak. Here's some normal ovaries, right? They're just egg-shaped, testicular almost. But then check out these streak ovaries circled in green, and you can tell they're just kind of barely there at all. So they're atrophied. They're there, they're just smaller. Here's a streak ovary singular. Took me a long time to figure out where this thing is, but to familiarize you, here is your uterus, and in blue here are two fallopian tubes popping laterally. And then so from this angle, the ovaries would be right underneath the fallopian tubes, again, from the angle that we're viewing at. So that means that this thing right here, this flat little ligamentous looking thing, that's an ovary, and it's unilateral. You don't see an ovary on the other side in this image here, but that's what a streak ovary looks like. Again, here's another good photo of it. And so you can imagine that if you have an ovary that's just paper thin, flat like that, then you don't really have a lot of oocytes up in there. And so fertility is absolutely a problem for patients born with Turner syndrome. Now, the external genitalia are not affected. It's just the ovaries that are pathologic. So why does that ovarian failure occur? We think it is hypothesized. Translation, you won't get asked about the nitty-gritty details. It is hypothesized there's a mechanism that selectively destroys meiotic oocytes carrying unpaired chromosomes. So if you have a 45X single X karyotype, what that means is that when you, if you're the 45X patient, when you go to produce germ cells, to produce eggs, through primary oogenesis, you're going to be making a lot of haploid cells that are basically partially empty as a result of you only having one sex chromosome. So because of that, like half of the eggs that you're going to be making are going to be deficient in some way because they just won't get a full set of chromosomes because you're missing that second X. So when that happens, your body's got a mechanism built in that just pops those oocytes through apoptosis. So resultantly, because of the single X genotype, you're going to see a drop of ovarian volume to approximately 1/2 that of 46XX females. And that manifests again grossly as the streak ovary. Now, you'll see low estrogen in these patients because the growth of granulosa cells is dependent upon the successful growth of follicles, folliculogenesis. Let's see if I kept that in here. No, I didn't keep that in there. So the granulosa cell is analogous to the Sertoli cell in men. And so understand the Sertoli cell takes testosterone and it's got aromatase, and so it can pop out estrogens. So if the granulosa cell is doing the same thing in women, then that's going to lead to a decreased estrogen content if you don't have those granulosa cells. So that's the ovarian failure. Let's talk about short stature. It's because they're missing one copy of the short stature homeobox gene located at the pseudoautosomal region of the X chromosome. And the pseudoautosomal region means it's like an autosome, but it's not. And so what's an autosome? Well, it's any chromosome that's not the X or the Y chromosome. So what makes it like an autosome? Well, it can just recombine with the other sex chromosome. And see, the majority of your sex chromosomes, you do not want them recombining. Why not? Well, because there are particular genes that confer a selective advantage to men that are on the Y chromosome, that if they went over to the X chromosome, they would actually be deleterious in females. And vice versa. There are a lot of genes on the X chromosome that confer some competitive advantage to females that if they were on the Y chromosome would turn out to be deleterious in men. So those sex-specific regions of each chromosome, we lock them down. We hypermethylate them almost immediately after that initial cell division because we don't want the Y chromosome and the X chromosome playing games with each other and recombining. Now, the little part of the Y and the X that we do allow to recombine is called the pseudoautosomal region. So there's high variance in this pseudoautosomal region, and thus a higher propensity for possible mistakes and mutations because it's less methylated, it's more transcriptionally active. And so that's where this SHOX gene, short stature homeobox, comes in. It's on the pseudoautosomal region, and so it is exposed to possible mutations. Now, if you only have one copy of the X chromosome, you only have one copy of the short stature homeobox gene, which means you're going to be short. I'm sorry. And then, really good part right here, tying it all together. The tall stature observed in Klinefelter is probably the result of a third copy of the SHOX gene. So that should give you a good idea of what it does. It determines height. Now, I can definitely see some sort of question coming out of the pathogenesis section of the Turner syndrome, half of this SDL. Clinical presentation, it's particular. You basically know that you're dealing with Turner syndrome when you see it due to the features such as cystic hygroma. And this here is cystic hygroma that I've outlined in yellow on the posterior nape of an infant who has acquired hydrops fetalis. Hydrops meaning essentially filled with water. And so you can tell there's a little kind of inflated appearance to that bright red fetus. But when we say Turner syndrome has particular findings, these are the sorts of things we're referring to with the broad shoulders and the shield chest. Just like Klinefelter syndrome, you're going to see a hypergonadotropic hypogonadism. So why is it hypogonadism? Well, you only have one X chromosome, and so you're making half the eggs that you ought to normally be making. So it's a loss of function. And then you're not going to have a lot of, what did we say, granulosa cells, because those are dependent on follicle cells to grow. And so if you don't have a lot of granulosa cells, well, then your brain is just going to throw LH and FSH down at your ovaries to try and kickstart them. And so that's the hypergonadotropic part. There's a high level of G and RH in the blood. The body habitus characteristic, like in Klinefelter's, you see lymphedema, and we believe that you see lymphedema and the sequelae due to a delay in the formation of, or rather the connection of lymphatics to the venous system. And remember that your lymphatics typically drain into your subclavian veins right there at the subclavian angles, right? And they spit just right back into the veins on the left and the right. And then important things travel in lymph, like fat derived from the intestines. What do we do with it? We put it in chylomicrons and it goes into our lymphatics, and then it gets dumped into the bloodstream. It doesn't go straight into the bloodstream because lipids aren't water soluble. And so there's some good things in fat soluble vitamins too that are going into the bloodstream from lymphatics. So the lymph empties into the circulation, and if there's a delay in that, then you might see such findings as a webbed neck, a low posterior headline, lymphedema of the hands and feet, and finally, excessive nevocellular nevi. That just sounds like something they'd want to ask you about, Now going back to the SHOX gene, short stature homeobox, because that, you only have one copy of that because you have one X chromosome. Well, what do you see as a result? Well, not just a short overall height, but a short neck, and maybe also a small jaw. That's called micrognathia. Genu valgus, that's going to be knees that kind of point inwards. Remember, a valgus stress is one coming from the outside, and a varus stress would be one that was like hitting from the inside. Short metacarpals and metatarsals. Scoliosis, so a lot of physical diagnostic findings here in Turner syndrome. Finally, sensory neural deafness has been reported in 50%, one half of adult Turner patients. So I've got a slide here quickly about the Weber and the Rennie test. And remember, the Weber test is going to be the one where you bop the tuning fork and put it right on top of their head. It's like you're making a W on their head. And then the Rennie test is going to be the one where you bop it and then you hold it up to their ear and you see, okay, how can you hear it on both sides? And then you bop it again and you put it right there kind of on the, what's that called? Mastoid process right behind the ear, you know? That's a mastoid process. Is that the mastoid process? Oh, I'm losing it. You put it on that bone right there behind the ear, you know, and then you see if air conduction is better than bone. And then the results of those two tests are going to let you know if there's the presence of a conductive or a sensory neural hearing loss. Or in a patient with a confirmed hearing loss, you can deduce if it's of conductive. So there's a problem in the three tiny bones of the ear and the eardrum. There's a mechanical problem, or sensory neural in origin, meaning you've got a problem with the vestibulocochlear nerve, cranial nerve 8, maybe it's passage through some of those very narrow passageways. Variant forms, not a big deal, you know, because all these things are named for how they look. So if they give you a fish and they say like ring chromosome, and it's like things sitting there looking like a Fruit Loop, it's like, I wonder if that's a ring chromosome, you know. So just stick and move on those. Here we go. Associated abnormalities, I'm calling a question from this section. I think it'll come from here, because things like bicuspid aortic valve, we've had that before, you know. So how many cusps should your aortic valve have? 3, right? So what's something that commonly happens to the aortic valve in a lot of people? It calcifies. So what type of murmur do you hear if you've got a calcified aortic valve? Well, you'd hear aortic stenosis, and so that's a hollow systolic crescendo decrescendo murmur, right? So about how old are patients when their nice normal tricuspid aortic valve starts to calcify? You can ballpark it like 60 to 70, around that decade would be a good guess. And so if you had a bicuspid aortic valve, could you see that there's more mechanical stress on 2 valves opening and closing again and again than there are on 3? So can you see that these 2 valves would accrue some damage a little bit more quickly than if there were 3 of them, and those damaged valves would be more prone to get some calcium depositions on and within them? So could you imagine that someone with a bicuspid aortic valve is going to experience aortic stenosis on average way earlier? We're talking 30s and 40s in life. So if you've got a stenotic aortic valve, that's a high preload or afterload? It's a high afterload, right? You're having to push against that valve and shove it open. So that's a high afterload. And so how does your heart compensate for that? Well, it just puts more blood into it, you know? And so it's going to Frank Starling force it and stretch a little bit more, push more blood out. And so because you got to generate higher pressures to pump blood out against that afterload, of course you're going to be hypertensive if you've got a calcified bicuspid aortic valve. There's no way you couldn't be hypertensive, you know? So because the aortic root is involved in this calcifying pathology, you also have an increased risk of aortic dissection. And this is probably going to be a type A because it's going to start right up there where the valve is. It's not going to be starting, you know, down in the thoracic or abdominal aorta, you know. That would be a type B, Stanford B. This one's probably going to be a type A, which is indicated for emergent surgery. So renal malformations, to understand that horseshoe kidney is very common in Turner syndrome. That means that you essentially have one kidney. And recall that it likes to get stuck as it progresses upwards. It ascends, your kidneys do. And the horseshoe kidney likes to get stuck on the inferior mesenteric artery. You might see something like ureteral duplication. That's not really a bad thing. Or at least there's a lot worse things out there. All Turner patients should have a renal ultrasound at diagnosis. Higher incidence of Hashimoto thyroiditis, which I think is going to be DR3. I might be blanking on that though. And finally, something that is not mentioned but is hand in hand with what's going on in Klinefelters, you've got a hypogonadism. You're going to have bone fractures. Because Turner patients, this is just the female version of a lot of what's going on in Klinefelters. It's hypergonadotropic hypogonadism. So the hypogonadism part means that for men, there's low testosterone, and for women, there's low estrogen. So if you're a Turner patient, then you're going to have low estrogen. So we know that estrogen protects bones because women get out of menopause and they start having these fractures left and right because they're losing the protective effect of estrogen. And so Turner patients are therefore at risk of osteoporosis. Here's a good graph showing you that around the start of puberty, notice that FSH is just going to go straight up in patients with Turner syndrome compared to controls. And this is mirroring the rise in FSH that we're seeing in patients with Klinefelter syndrome, again, because this is a hypergonadotropic hypogonadism. And so this is evidence of the hypergonadotropic part. So that's your associations, and you understand what's causing these pathologies, especially nondisjunction. Brush up on nondisjunction. And one more time in Klinefelter, what's causing the androgen problems is this non-random X inactivation, meaning that you're going to leave active the worst androgen receptor out of the two that you have amongst these two X chromosomes. That's a weird way to say it, but I wish there's a more condensed way to say it. But just read that paragraph at the top of page 7 if you're still not getting it. And other than that, we've got hyalinization of these seminiferous tubules because there's not a lot of testosterone there, right? And then we've got Leydig cell hyperplasia due to that very, very high LH in the blood. And that's characteristic. Thanks very much.